Saturday 33.
अभी आलाय सर.
Hello everybody, greetings from HeartCare Foundation of India. I am Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. This is our 31st roundtable. Every week we meet and every week we come out with some policy advisory. Couple of days back, I was with the President of World Medical Association. He is also the past national president of American Medical Association. And he said that when I told him that our countries of the Asia are meeting every week, and he says, way, this doesn't happen in European countries. People don't sit and decide the policies. So whatever we are doing is something which circulates, because our roundtable discussions ultimately get consensus from IMA and CIMAO countries. So it's a work we are doing in a significant manner. I hand it over to Dr. Kalra to start the meeting.
Thank you, sir. Good morning to all the roundtable experts. Today is our 33rd meeting of the roundtable expert group on COVID. And as we know, most of the cases of COVID infection are mild or moderate, but definitely some percentage, 10 to 15 or less, they become serious. So it's very important. We do not know who will become serious. There are risk factors. We need to make an assessment of regarding every patient of COVID-19, maybe whether it is ourselves, in our family members, or in the society, or our patients. So there are certain clinical, we need to discuss the clinical as well as non-clinical or laboratory parameters which suggest or indicate maybe in that particular patient it may turn into serious, so that proactive approach is taken and the required drugs are given, prescribed and given to avoid the complications which are known in certain patients of COVID-19. So this is a topic today we'll be discussing. Now, I hand over again back to Dr. K.K. Agarwal to give the introduction and then start discussion.
Today's chair.
Let it be Upasana today, Madam Upasana.
Madam Upasana to chair, and Dr. Mahesh Verma will sum up the meeting. In the last 10 minutes of the meeting, we will also have how to make a Diwali gift. So we have Department of Science and Technology who have sent us Javed Alam, who will be showing us a new way of preparing a Diwali gift, which you can prepare it at home at no cost, and which is a good Diwali gift. So he will tell us how to make in a jar of water, how to build up a plant, which plants can be built up, and they can be distributed as a Diwali gift, because Diwali is coming. So these are the Diwali gifts which are zero cost Diwali gifts. Now coming back to the subject, I've been debating myself in this subject. Can cytokine crisis be prevented? That means, can I predict that this patient is going to go into cytokine crisis? Can it be predicted? So I'm going to come up with two hypotheses. Hypothesis number one. Up till now, we have been talking about prevention of virus. When we talk about ivermectin, hydroxychloroquine, we have been talking about not getting a disease, which I am not discussing, not touching. I'm basically touching it. If I get a disease, can I prevent my cytokine crisis? With that in assumption, we have two assumptions. One, can I give a drug or a herb while patient is day 0, and if he takes it, he gets a virus, cytokine crisis will not come. That's assumption number 1. Assumption number 2 is that he develops a disease, he goes through a viral procedure. On day 1, you give him something and you prevent a cytokine crisis. If that happens, then it will be, if you get it, so what? You get a illness for 4 days, and after 4 days, your illness will go away. Normally, a viral illness should last for 4 days. And after 4 days, you take 3 days to recover. So it's a 7 days illness. So can I convert my illness into a 3 to 4 days illness? These are the two hypotheses I am talking about. But before that, it's a time for weekly statistics. The weekly statistics is, this is up to date till 7 o'clock in the morning. I built it up at 7 to 8 in the morning. We can see world over, there are 3 waves. And we can see also there are 3 waves of mortality. And the waves of mortality are like the waves of the new cases. We can see in India, we have only 1 wave so far. And that 1 wave is also showing, mortality is also showing the same pattern. Within India, we can see Delhi is showing 3 waves. Delhi is showing 3 waves. And the second wave and the third wave, mortality is also reducing. We can see Maharashtra showing only a 1 wave, and that wave is declining. We can see Kerala also, if I take this as the first wave, then this is the second wave. This as the first wave, then there is a gap. So this is a second wave in Kerala. The mortality parallels with the number of cases. If I go to Odisha, it is the first wave. Mortality is also in parallel with the first wave. Means this graph pattern and this graph pattern are the same. This is Bihar, we have the first wave. We have Rajasthan, we have the first wave, which is rising, rising, and rising, and rising. And now it is declining. Then we have USA. You can see here in USA, we have 3 waves. The mortality is also just the reverse. Maximum mortality, but the mortality is showing a reverse pattern. See, there are 2 different graphs. If you can see the graph here, the mortality and number of cases follow the same pattern in India. But in USA, it is the reverse. That means this is like a mirror image of this. Less cases, more mortality, more cases, less mortality. Canada, again showing the same. Less cases, more mortality, more cases, less mortality.
Dr. KK, are you showing the slides?
Sir, you
Because we can't see the slides.
Oh my God, my mistake, my mistake. Is it over now?
Yes, now it's
My mistake. I thought I was showing the slides. So this is world over. You can see 3 waves and 3 patterns of mortality. You can see India, 1 wave, mortality follows the wave. More the number of cases, more the mortality. Less the number of cases, less the mortality. This is Delhi. This is Delhi, 3 waves, but mortality reduces. This is Maharashtra, only 1 wave. This is Kerala, 2 waves. We have 1 wave, gap, second wave, mortality following the same. We have Odisha, 1 wave, same mortality pattern. Bihar, 1 wave, same mortality pattern. unless you call this as a one wave, first wave, then you can say this is a second wave. Rajasthan, again, you can see the same pattern. Karnataka, you can see the same pattern. USA, just the reverse pattern. See here, less cases, more mortality. More cases, less mortality. Canada, same. Less cases, more mortality than gap. Then more cases, less mortality. Argentina is showing again the same thing, same pattern. It is more the cases, more the mortality. Peru, less cases, more mortality, more cases, less mortality. Iran, following exactly like India, less cases, less mortality, more cases, more mortality. This is Russia. In Iran, we have three waves, three mortality patterns are same. Iraq, we have same pattern of mortality and number of cases. UK, reverse. Less cases, more mortality, more cases, less mortality. Italy like UK, Germany like UK, Spain like UK, Mexico behaving like India, more cases, more mortality. Hong Kong, it is also following only one wave. Then Taiwan, we have only one wave. France, we have less cases, more mortality, more cases, less mortality. South Korea, it is following the same, more cases, more mortality, less cases, less mortality. Indonesia following the number of cases pattern. Brazil, same. Saudi, same. Pakistan, same pattern. Nepal, same pattern. They all are pattern means, so we are getting two distinct patterns. One pattern we are getting more the number of cases, more the mortality. Second pattern we are getting is less the cases, more the mortality, more the cases, less the mortality. Singapore, again, mortality is hardly any. China, there is no mortality. Australia, again, we are following more cases, less mortality, less cases, more mortality. Lanka, hardly any cases. Thailand, again the same, more cases, one peak matching the second peak. Malaysia, again we can see less cases, more mortality. So this is what I am talking about. This was my first weekly part. So we are getting two distinct type of patterns. One pattern is showing more mortality with less cases, and more the cases, less the mortality, less the cases, more the mortality. And the second type of a pattern we are getting is in countries where more the number of cases, more the mortality. The graph matches with number of cases, so mortality is constant. I have not yet correlated it with the per million population. Now we come back to can cytokine crisis be prevented? Can cytokine crisis be prevented? But before that, I have been talking about, yes, in our roundtable, we did a guideline about mouthwash, about povidone iodine. And now it has been published in an international journal of dental research that all doctors should do 3 days in a week, 3 times in a day mouthwash to reduce the virus load. Now I'm coming back to the concept of COVID-19. And the concept of COVID-19 is based on this line, and the line is, this line is the whole basis of today's discussion. And the line is, in patients with COVID-19, we see a relentless self-amplifying cycle of inflammation and clotting in the body. Now, inflammation is inevitable. Therefore, if a patient gets COVID-19, he will get inflammation. Inflammation will be over by 4th day, and the seriousness will be over. But if he ends up into a self-amplifying cycle of inflammation and clotting in the body, now the disease ultimately ends up into a cytokine cross. Why? Clotting precipitates inflammation. Inflammation causes further clotting. Inflammation here is TNF alpha, IL-6, IL-1 beta, IL-8, and IL-18. And clotting here is high fibrinogen level, which are because of IL-6. Therefore, if we can prevent the clotting, we won the game. Therefore, now all the studies in the last 1 week are telling that if at day 0 in high risk people, if we give them aspirin prophylaxis along with statin, if their LDL is more than 70, in that particular case, when he develops COVID-19, you are preventing formation of white clot, which is platelet clot. Once platelet clot is formed, then over that a red clot is formed, for which we require an oral anticoagulation. So the hypothesis which has been accepted all over is, number 1, if you are a high risk, take aspirin prophylactic. High risk means your CRP is between 1 and 3. And if you are not taking aspirin, and if you develop COVID-19 and your baseline CRP is 1 to 3, then you immediately start oral anticoagulation to take care of that. Now, for this, we need a criteria to start. And how do you know that your cytokine crisis has been prevented? For that, we need some numbers. And that's what I'm now going to talk about, numbers. So the first is COVID-19 is associated with acute inflammatory change, leading to DIC, increased fibrinogen and increased D-dimer. And the risk of thromboembolic phenomena is 43%. And now this is very, very important, which I have taken from the reference. And I got a clarification from the WMA president, who is also the AMA president, past AMA president. So I got a line from the literature that all inpatients should receive thromboprophylaxis unless contraindicated. So when I talked to the AMA president, past AMA president, what do you mean by this sentence? He says, we do not have any policy of home care in US. Our policy is every patient is an inpatient. If that's so, our previous roundtable guideline that every patient on diagnosis should be given thromboprophylaxis gets validated. Up till now, we used to think a criteria of admission means seriousness. But he said, no, the criteria for admission is contagiousness also. Now, this is another study which has talked about anti-phospholipid antibodies. And they said that 75% of the people have this antibody in the blood. Moderate to high titers were evident in roughly 2/3 of positive samples. This confirms that 75% of the people will have hypercoagulable state. And this hypercoagulable state can be prevented by dipyridamole, according to this study. But we know aspirin is another drug which reduces the hypercoagulable state. Now I come back to a simple phenomena, that is C-reactive protein. Now, if I take CRP as a parameter, C-reactive protein, simple test, 150 rupees, available everywhere. Now I want to classify that CRP will start rising in 4 to 6 hours. So the virus enters my body. Once the virus starts replicating, comes out of the cell, identified by CD8 and NK cells, they will release cytokines, and CRP will begin rising within 4 to 6 hours of the stimulus. 4 घंटे में CRP बढ़ जाएगा. Now see, doubling every 8 hours, peaking at 36 to 50 hours. So by day 2, CRP should peak. By day 2, CRP should peak. And it should come back to normal within 19 hours. Removal of the stimulus, it should come back to normal in 19 hours. CRP will remain elevated if the underlying cause persists. यहाँ पे आ जाएगा वो inflammation begets thrombus, thrombus begets inflammation. So इसकी बेस डे 4 तक अगर आपका CRP नॉर्मल आ गया, इस पेशेंट को कुछ नहीं करना. Nothing to be done for this patient. In some patients, CRP will become normal by day 8. तो ये लोग क्या कह रहे हैं? If you have, you know your zero CRP level, 0 day. Suppose your 0 day CRP is 4, then by 4th day it should come back to 4. Leave the patient as it is. If on day 4 you find it 8, double, that means it is double the value of normal, you will say slow response pattern. But in a non-response pattern, CRP will go on rising. In some cases, you will get a biphasic response. Here, when we are finding a non-response versus slow response, we needed a number. What can be that number? Then I started looking for various and our own experience. And the number we got was, the cutoff was 10. If the CRP is more than 10, in 1000 patients data I have seen, if the CRP is more than 10, by day 10, so we created a formula that if your CRP is more than 10 by after day 10, it is leading towards a cytokine reaction. That number 10 we have been able to build up. And then there are lots of references here which gives the severity of cytokines. They says by day 10 is actually a day 8. If by day 10 your CRP is more than 100, more than 40, more than 26. But one thing we have seen very clearly, that on day 3, when your CRP should start declining, if on day 3 your CRP is more than 10, or you have a new onset cough, or if you have fever more than 101. Remember, COVID fever is always less than 100. If your fever is more than 101, it's a cytokine fever. So cytokine reaction at the onset is day 3, day 4, and day 5. And by day 3, day 4, and day 5, if your CRP has not come back to normal, if your fever is more than 101, or if you have a new onset of cough, cytokine chain has started. To prevent this, the only way to prevent is, in all such cases, start oral anticoagulation on day 1 or aspirin before day 1. Then you can prevent this cascade of inflammation. That is inflammation leading to clot, clot leading to inflammation. These are the cutoff values, various values which are given here. So I wanted to talk about one more thing, and that is CRP daily ratio and CRP doubling time. And this says CRP doubling time is how much time CRP takes to double. Normally, it should double within 8 hours. Doubling time is 8 hours. So you can also calculate that if your CRP is doubling after day 4, you know that CRP is rising, rising, and rising. Second is your CRP ratio on day 4 divided by day 0. That will also tell you whether your CRP is rising or reducing with that particular thing. So the whole idea of this presentation is if you want to reduce the mortality, on day 0, if the person has a C-reactive protein of more than 1, there is a Jupiter trial which has shown that a CRP of more than 2 can be reduced by aspirin and atorvastatin, and you can reduce the number of heart attacks in the future. That's a old aged study available to us. So my observations are that all of us sitting here are at a high risk people. If we are taking aspirin, if not contraindicated during COVID era, and that aspirin will prevent platelet aggregation, the virus will come and go. And if we still get a COVID-19 and our CRP is more than 10, that's a sign of cytokine reaction. So CRP more than 10 on any time of the illness is a cytokine reaction, which means cytokine chain has started. This number, I am working on it for the last 4 months. I have now confirmed it over 1,000 patients. I have a data of 1,000 patients with me. I have yet to get a patient with a CRP of more than 10 not having pneumonia on the X-ray. And then the severity of pneumonia will vary with the severity of the CRP. So therefore, the criteria is that if you bring your CRP to less than 10 by day 4, but definitely bring your CRP to less than 2 by day 4, or bring it to the baseline by day 4 or by day 8. For that, the only answer is aspirin or oral anticoagulation. And if still the patient doesn't respond, then steroids are the answer. In our data, whatever I have seen, where we are giving early anticoagulation, I have only lost 3 wickets till today. One of them was on dialysis. Another one was 84-year-old. And one of them was 75-year-old. All we have been able to retain the wickets in the people. So I end my case by saying CRP more than 10 by day 10. If you can bring it down to less than 10 by day 10, you have won over the cytokine crisis. And if you can bring your CRP to the normal baseline level by day 5, you have 100% guarantee the patient nothing is going to happen. Back to Dr. Kalra. So instead of going into other parameters, there are so many parameters: eosinophilic count, TLC count, D-dimer count. There are thousands of parameters available. I have concentrated on the one parameter which can be available throughout the country, in every village, in every place. So my focus was only on one parameter to bring it. Dr. Kalra.
So thank you everyone, and it's my privilege that I am chairing this session. And Dr. Agarwal, today's session was really very, very good and knowledgeable, because CRP everybody is doing in every hospital. So if we can track this, so we can prevent, as you said, we can prevent cytokinase. So it is going to help every patient. And I was noting your notes. We should get your slides on our mails. So it is going to be very helpful, because now I will distribute among my doctors, so they should also understand your studies. So I think who is our next speaker? He has to.
Dr. Jay Krishan, everybody to make comments. Dr. Jay Krishan, because 11:45 we will have a 10-minute Diwali gift presentation. Dr. Jay Krishan.
It's very pertinent that we had discussed mortality prevention in our previous issues, and many of the points were discussed. But it's very important that a single parameter, that CRP, which is being universally done in almost all the labs, can be used as a prognostic factor and its use for mortality reduction is a very important thing, and this should be meticulously followed, and this message should be communicated to all. Thank you.
Dr. Arun Agrawal, kindly.
Thank you. Thank you, Dr. K.K. Agarwal, for giving us something very valuable. And we have learned a lot. I have a couple of comments. Number one comment regarding your epidemiological data which you have presented for the entire globe. Of course, what I wanted that when we talk about India and our neighboring countries, say SAARC countries, whether it is Bangladesh or India or Nepal or Pakistan, I think can we have a collective data of SAARC countries so that let us assess that are we doing the same way as other our neighboring countries do. This is number one, because obviously the pattern of European countries and US and other countries may be different. So let us, with number one, we would like to have some sort of data which indicates are we different among our own neighboring countries or we are the same. This is number one. Number two, you did mention about the article which has been published, iodine, and that is betadine gargle. And I remember once we were having discussion with our dental colleague headed by Dr. Mahesh Verma, and they also recommended hydrogen peroxide. So do you think a readily available hydrogen peroxide will be equally effective? That is my second question. The third one is that, believe me, the way you have described the day 0, day 1 to day 4 progress, 4 to 7 days progress, 7 to 10 days progress, and thereafter, right? And you have indicated perhaps one important test is CRP. I fully agree, because today in the diagnostic field, there are so many parameters available and everybody is recommending, and the patient themselves says, "Ki doctor, ye to karai lijiye." Each patient has become 75% doctor. Not only in naming them, but perhaps in interpreting them also. So in case we can convey this message that CRP is the single most criteria, perhaps it will definitely decrease the load of testing being undertaken on one patient, but the cost also, and unnecessary tests can be avoided. Of course, your observation regarding aspirin is wonderful. I think many of us are taking some sort of aspirin. Here, I would like to ask you, like Ecospirin 75 milligram will do, or it should be 150 milligram? There are few questions in my mind, and I will come back to you when I get the opportunity.
Thank you, Dr. Arun. Hydrogen peroxide is a substitute. Yes, you can substitute it with hydrogen peroxide depending upon the cost. Whichever is cheaper can be given as a prevention. Aspirin dose, we normally talk about 75 milligram for coronary artery disease, but here I think 150 milligram will be better because you need a little bit more stronger antithrombotic action. 30% of the cases still will develop hypercoagulable state. Therefore, over aspirin, you may still require oral anticoagulation on day 1 in highly cases. Third is when we see the pattern. If I see the pattern, I'm saying today we have decided our next CMAO topic will be racial distribution and patterns. Instead of a country-wise, we are trying to find out racial distribution, different races, and their patterns are the same or not. Because what we are getting is Korea, China, Singapore, and Hong Kong, Taiwan, their pattern is one. All European countries' pattern is one. Then we are getting all American countries' pattern is one. Then we are getting all Saudi Arabian countries pattern is 1. And then we are getting India, Pakistan, Nepal, Bangladesh pattern is 1. Thailand, Myanmar, all these patterns are 1. So I'm going to have all of them traced in a single slide and present it next time, because there are different types of patterns being seen in the world in terms of mortality and in terms of new cases.
जी डॉक्टर अशोक प्लीज बताइए. You are mute, Dr. Ashok. You are mute.
Yeah, thank you, Dr. KK. An excellent presentation and a great information for us at such a high risk, 65 plus. And in continuation to what you said in the last answer to Dr. Arun Agrawal, do you have any data about the mortality rate being high with the infrastructure related, like a tertiary care hospital, the mortality, the secondary care hospital and in non-metro cities? Is there any difference in Indian scenario and other countries where the mortality becomes higher with the COVID positive, with all of the parameters being same? Is there any difference? Because if we take care of the patients in a tertiary care hospital and mortality still remains the same mortality rate, then we are missing out something in the overall care. That's my personal feeling as a non-physician. So I would be very happy if we can include this data also if it is available. Thank you, Dr.
If infrastructure was a concern, then the mortality should have been lowest in America. So therefore, we started working on that. Infrastructure cannot be the only criteria, because the mortality amongst America is very high. In Europe, it is the highest. So if infrastructure was the responsibility, then we found out from China, South Korea, Taiwan, Hong Kong, and Singapore. And their infrastructure vis-a-vis European infrastructure and vis-a-vis American infrastructure. And we found a sparkling difference. And the difference was availability of the AI rooms. In America and in England and in Europe, they don't have communicable diseases. So they don't have so many of AII rooms as these countries who have experienced SARS and MERS they have. So that's the only difference we got. That in because when from day one in China, South Korea, in these countries, from day one they have a triage system where their healthcare workers' involvement is practically zero, because they have AII rooms. Otherwise, there is no difference.
Yeah. So before I want that Dr. Jailal should also speak regarding today's presentation. But Dr. Agrawal, before that, I wish kindly you can tell us how Sri Lanka is able to make their infection rate so less. Is there any mechanism they are following or something related to environment?
The only answer it comes is that they were from India. Sri Lanka has the same type of a population as Kerala. So in Kerala, we were getting the same response as Sri Lanka till now. Now we are getting a surge in Kerala. And if that's so, then we are expecting a surge in Sri Lanka the way Kerala has got a surge. That is education of the society. That's all.
Kindly, Dr. Jailal, please speak something about today's presentation. Yeah.
Very much, madam. And I think now it is very good that we are focusing on single factors instead of multiple factor studying. If this concept of CRP estimation and coming to a conclusion based on that, I mean, that will be much easier for the general practitioners and the mass variety of doctors who are now a trend is setting in, and every practitioner is now about to see the COVID cases. The dedicated centers or designated centers alone cannot match that, because people are going offhand to the many doctors. So it is necessary. We need to shift the focus from a structured, full-blown protocol to the protocol which can be done at a secondary level hospital and a primary level hospital. So that is very important. And as usual, Dr. KK has taken that initiative. And this is because CRP and every practitioner is used to it. I mean, probably the ferritin and looking for the interleukin may not be, they are not acclimatized to that, but when talking about CRP, it will be very good. And another point which you raised is the Sri Lanka, but I mean, I'm not sure whether it is exactly right, but what we personally feel is that the structured pattern of a medical practice available in Sri Lanka. There, the family practitioners concept is prevalent everywhere, and they have a very, very formative or organized pattern where the family practitioners will be able to do, and before going to the consultants or before going to the senior level doctors, and they always have the system of the three-tier system which is persisting there. And not only this, if you see the Kerala and Malaria, Sri Lanka cannot be compared in one condition is the malaria. In Kerala, still the malaria is prevalent. But Sri Lanka, with the vast experience of all their coastal belt, they is a malaria-free country. And their infant mortality and their maternal mortality is much, much lesser than us. So there is something more than that, not only the education system, but probably the one system of medicine which they follow is a family medicine system. And that is one of the reasons why they are still get very less, and the mortality based on million people is very less. I mean, less than 9. So it is a great achievement. So thanks to Dr. KK for once again bringing out a simple and adaptive method. Normally, I hear that KK sir will talk on the high-end end, but now today it's one issue which everyone can practice is been put forth by KK sir. So thank you on behalf of Indian Medical Association for this initiative, sir.
Thank you, Dr. Jalal, because today we have some presentation also. So now I would like to ask Dr. Mahesh Verma ji. He has to compile whole days.
Before that, Aparna ji, before that, we'll have a 10 minutes Javed ji's presentation, and then Mahesh ji to sum up that also.
Dr. Rai is also here if he has any comment, short comment to give.
Ji, Dr. Rai. So first we will go for presentation.
Okay.
Mr. Javed, kindly. Javed ji, if you can hear, kindly start your presentation. Yeah, thank you so much. Mr. Javed, please start your presentation. We are waiting.
Yes, ma'am. Welcome all participants of 27th Digital MTN Perfect Health मेला. आज के दिन भी हमारा टॉपिक हाइड्रोपोनिक ही है, लेकिन आज के दिन मैंने हाइड्रोपोनिक्स को एक दूसरे नए अंदाज में प्रेजेंट करने का कोशिश किया हूँ. इसलिए इस पूरे हाइड्रोपोनिक्स को हम लोगों ने 3 पार्ट में डिवाइड किया है. वन पार्ट इज कॉल्ड डोमेस्टिक हाइड्रोपोनिक्स, जो घरों में डेकोरेशन के लिए, ग्रीनरी के लिए, ब्यूटिफिकेशन के लिए जिस सिस्टम यूज करते हैं थ्रू हाइड्रोपोनिक्स इज कॉल्ड डोमेस्टिक हाइड्रोपोनिक्स. सेकंड एस्पेक्ट कमर्शियल हाइड्रोपोनिक्स, जो पाइप में प्रोडक्शन देख रहे हैं वेजिटेबल्स का, उसको बात करेंगे, कमर्शियल हाइड्रोपोनिक्स. एंड थर्ड इज वन द मोस्ट हाई कमर्शियल इज कॉल्ड aquaponics, aquarium aquaponics. So less productive and commercial, more commercial and high commercial. इस 3 एस्पेक्ट में आज बात करेंगे. On the whole, hydroponics is a method system to grow a plant without soil is called hydroponics using an nutrient. तो इसमें हम लोगों ने पौधों को ग्रो करने की कोशिश करते हैं बिना मिट्टी के, पानी, बालू, पत्थर, कोकोपीट आगे में, और कोई सा न्यूट्रिएंट इस्तेमाल करते हैं. तो इसके लिए 4-5 चीजों की जरूरत पड़ती है. 5 मटेरियल. 1 फर्स्ट इज द प्लांट, पौधा. वो विदाउट रूट भी हो सकता है और विद रूट भी हो सकता है. जो पौधे जैसे लगते हैं, जो कटिंग से तो कटिंग से ले लेंगे, जो रूट से रहते हैं रूट से मट्टी से उखाड़ लेंगे, इसमें थोड़ी मिट्टी लगी है साफ कर लेंगे, और फिर ये प्लांट हमारा हाइड्रोपोनिक्स से लगाने के लायक तैयार हो गया. अब इन पौधों को जिस पॉट में लगाना है वो पॉट लेंगे. वो पॉट हमारा 2 तरह का हो सकता है. एक नॉन डिग्रेडेबल वेस्ट पॉट्स लाइक दिस, सॉस का हवा, ये बोतल का हो गया, ये पीवीसी कप हो गया, ये ग्लास हो गया, इवन जार हो गया, इवन दिस बोतल हो गया, और ये दही का पैक हो गया। 90% मटेरियल, और दीज आर द फैंसी पॉट्स और बेटर और अच्छा लुक के लिए। थर्ड इज द मीडिया में वन इज द वाटर कल्चर, पानी लिया उसके वाटर कल्चर मेथड, सेकंड सैंड, थर्ड स्टोन एंड फोर इज द कोकोपीट। ये 4 अलग अलग मीडिया है प्लांट्स को ग्रो करने के लिए और सॉइल को रिप्लेस करने के लिए। एंड फोर्थ वन इज द वाटर इटसेल्फ, वाटर मीडिया। एंड फिफ्थ वन is the most important one is called plant nutrient, plant food. Here we are using this biofilm as a nutrient for plants. Mix 1 ml in 1 liter water, डाइल्यूट करके इसे यूज करने का है। सबसे पहले हम लोग प्लांट को यूज करने बनाने के पहले इसे न्यूट्रिएंट यूज करेंगे। 30 ड्रॉप्स इन 1 liter वाटर यूज करना है। 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 23, 24, 25, 26, 27, 28, 29, 30। या ये 100% प्लांट एक्सट्रैक्ट है जो एग्रीकल्चर वेस्ट और एनिमल वेस्ट का ये रेसिड्यू है। तो इसमें 1-2 गुना ज्यादा भी हो जाए तो कहीं कोई हार्म की बात नहीं है, 100% नॉन टॉक्सिक है। अब जिस प्लांट को जिस पॉट में लगाना है वो प्लांट लेंगे और वो पॉट में उस प्लांट को डाल देंगे, है ना। अब जो बनाया सोल्यूशन हमने, इस सोल्यूशन को इस पॉट में डालेंगे इतना, इसमें रूट्स नहीं है तो कटिंग एंड हमारा 1.5 से 2 इंच डीप हो जाए। ये प्लांट विदाउट रूट्स इन वाटर कल्चर रेडी हो गया। दूसरा, प्लांट विद रूट इन वाटर कल्चर, पॉट में प्लांट डालेंगे, ये सोल्यूशन जो बना न्यूट्रिएंट्स डालेंगे इसमें और टू द रूट लेवल, है ना, इसके रूट्स जो है सवाल के वो रूट्स हमारे डीप हो जाए। इस तरह कोई भी पौधे जड़ सहित जड़ रहित दोनों तरह के पौधे को हम लोग लगा के आगे बढ़ा के अपना यूज कर सकते हैं। अब इन पौधों को ऐसी जगह रखेंगे जहां तेज धूप ना हो, तेज हवा ना हो और अंधकार ना हो। फिर कुछ दिन के बाद इसमें जड़ नहीं है, इसमें जड़ निकल आएगी। इसमें जड़ अगर है भी तो वो सॉइल जो रूट्स है वो सॉइल ऐसे डिके कर जाएगी और नए हाइड्रोपोनिक के रूट्स निकल आएंगे। फिर सेट करने के बाद एज यू लाइक अकॉर्डिंग टू द नीड ऑफ योर्स, आप अपने अनुसार इन पौधों को प्लेस कर सकते हैं, चाहे वो इंडोर हो या आउटडोर हो। सिर्फ एक फर्क रखना है कि अगर ये पौधे हमारे फूल वाले हैं तो उनको 6 से 4 घंटा धूप चाहिए। पत्ते वाले के लिए कहीं कोई कंडीशन नहीं है, जहां मर्जी वहां रखें आप। इस तरह पौधों को हम लोग कुछ वेस्ट पॉट में और कोई फैंसी पॉट में लगा सकते हैं। इन सब पौधों के लिए जो 4 एस्पेक्ट्स हैं, पहला एजुकेशनल एस्पेक्ट, दूसरा सोशल एस्पेक्ट, तीसरा एनवायरमेंटल एस्पेक्ट और चौथा कमर्शियल एस्पेक्ट। तो फर्स्ट एनवायरमेंटल एस्पेक्ट, एजुकेशनल एस्पेक्ट में पौधे पढ़ाई के लिए, पढ़ने के लिए, पढ़ाने के लिए और रिसर्च करने के लिए ये प्लांट लगाया। प्लांट में क्या डेवलपमेंट आ रहा है, क्या इसमें इंक्रीज हुआ, ये नोट करने के लिए ये प्लांट्स के रूट्स के मेजरमेंट कर सकते हैं इसमें स्केल डाल के कि कौन सा प्लांट रूट अगर नहीं है तो रूट्स कब निकला, कितना निकला, कैसे निकला, और अगर निकला तो रूट्स कौन सा है, टैप रूट और वेंटिशियस रूट। टैप रूट अगर है तो कौन सा पार्ट है, प्राइमरी रूट, सेकेंडरी रूट, टर्शियरी रूट, रूट है। इसके साथ साथ ये रूट निकल के आया कि ये कितना वाटर एब्जॉर्ब कर रहा है, कंज्यूम कर रहा है, कितने टेम्परेचर पर, गर्मी में कितना करता है, जाड़ा में कितना करता है, बरसात में कितना करता है, तो 10 डिग्री पर, 20 डिग्री पर, 30 डिग्री पर, 40 डिग्री पर। तो अकॉर्डिंग टू द टेम्परेचर हम ये एसेस कर सकते हैं कि हमारे पास अगर 4 पौधे हैं और टेम्परेचर हमारा 30 to 40 के बीच में है तो हमारा पर डे 4 से 5 लीटर वाटर कंज्यूम होगा इन सॉइल कंडीशन। बट सॉइललेस एक पौधे में 6-8 इंच पौधे में एक साल में 1 लीटर वाटर एंड 1 ml का कंजम्पशन है। ये बहुत कम कंजम्पशन होगा। जो भी कंजम्पशन है उसको भी हम लोग यहाँ रीडिंग करके ये एसेस कर सकते हैं कि पर डे हर 2 दिन पर 3 दिन पर कितना वाटर ये कंज्यूम कर रहा है, और उसी कंजम्पशन के हिसाब से और वाटर की अवेलेबिलिटी के हिसाब से हम नंबर ऑफ प्लांट्स और प्लांट का जो वैरायटी है वो चूज करके अपने गार्डन में लगा के गार्डन को वेल मेंटेन और ग्रीन एंड हेल्दी रख सकते हैं। दूसरा मीडिया हमारा है ये बालू, तीसरा है ये पत्थर और चौथा है ये हमारा कोकोपीट। इस तीनों चारों मीडिया, इस सारा मीडिया सॉइल का बेटर रिप्लेसमेंट है। जो मीडिया यूज करना है, जो मेरे पास है, उसको उस पॉट में डाल देंगे, और जैसे मिट्टी डालते हैं गमलों में, और फिर उसमें जो पौधा लगाते हैं पौधा लगा देंगे। और ये जो सोल्यूशन बनाया हमने, ये सोल्यूशन इस चारों पॉट मीडिया में डालेंगे इतना कि ये ऊपर तक भींगा जाए। कुछ दिन के बाद ये वाटर कुछ प्लांट कंज्यूम करेगा, कुछ लॉस होगा, ये सूखेगा। जो अपर लेवल सूखा हुआ दिखे बालू में, पत्थर में या कोकोपीट में, तो इसमें ऐड करेंगे। वाटर लेवल में तो जो वाटर का लेवल है ये बाहर से विजिबल होगा, जस्ट कितना वाटर कंज्यूम हुआ अप टू द रूट लेवल, ये ध्यान देना है। रूट में अगर है तो कटिंग 1.5 से 2 इंच डीप पर है, और फिर इसके बाद इसमें टाइम टू टाइम ऐड करते जाएंगे, और महीने में क्या 2 बार 3 बार और चलता जाएगा। इस तरह इनको फैंसी पॉट में भी कर सकते हैं, ये बड़े बड़े पॉट में कर सकते हैं। फैंसी पॉट में अगर पॉट थोड़े बड़े हैं, स्पेस ज्यादा है, तब इसमें एक्वेरियम फिश भी डाल सकते हैं, मोर ब्यूटिफिकेशन के, डेकोरेशन के लिए। इस तरह से नाउ इट बिकम ए प्लांट एक्वेरियम। तो एक ही साथ आप एक्वेरियम भी और प्लांट का, ये दोनों का मजा ले सकते हैं, और काम ले सकते हैं, तो ये ज्यादा बेनिफिशियल होगा। ये सब एक्टिविटी के लिए कुछ एक्टिविटी बुक्स भी है, हिंदी में है, इंग्लिश में है। इसमें 150 एक्टिविटी, 30 एक्टिविटी और 10 एक्टिविटी दी गई है। इसके लिए कुछ एक्टिविटी किट बैग भी है। इस किट बैग में बहुत सा सॉफ्टवेयर, हार्डवेयर दिया गया है, जो पूरी सॉइललेस गार्डनिंग के लिए ये पूरा किट बैग है, जो एक्टिविटी चलती रहती होती रहती है। अब थोड़ा देखेंगे हम लोग कि इसी एक्टिविटी को कमर्शियली कैसे करेंगे, या कमर्शियल लेवल पर अदर क्रॉप्स प्लांट्स कैसे ग्रो करेंगे। तो इसके लिए जो
लास्ट करिएगा, लास्ट इसको लास्ट कर दीजिएगा।
ये पाइप होता है, इस पाइप में ये होल बने हैं, होल में ये हमारे छोटे छोटे पॉट्स में ये प्लांट्स लगे हैं, प्लांट्स के रूट्स, और ये होल में ये वाटर कल्चर है। होल में ये सोल्यूशन डाला हुआ है, सोल्यूशन यहाँ से हम डालते हैं इनलेट से, ये कनेक्शन से, और फिर अब क्या है, जो एक्सेस होता है वहां से फिर निकल जाता है, और रिसाइक्लिंग भी करते हैं। और ये सॉइल कल्चर में भी इसको हम लोग यूज करते हैं। इस तरह से ये जो हमारा एडिबल वेजिटेबल्स है, फ्लावर्स है, इस तरह से ग्रो करके एक कमर्शियल एस्पेक्ट दिया जा सकता है इस हाइड्रोपोनिक का, और द इनकम जनरेशन। लेकिन टेक्नोलॉजी और भी हमारे पास है, या लोगों के पास अवेलेबल है। ये इज कॉल्ड एक्वापोनिक्स। एक्वापोनिक्स साइंस, जिसमें हाइड्रोपोनिक में हम लोग प्लांट के साथ फिश भी यूज करते हैं, या फिश के साथ प्लांट यूज करते हैं। जो भी देखा प्लांट एक्वेरियम में, वो फॉर डेकोरेशन है। यहाँ कमर्शियल एस्पेक्ट में एक फिश टैंक है, ये फिश टैंक है, और फिश टैंक में क्लोज, और ये फिश टैंक में हमारी ये फिशेज हैं, ये फिटिंग दिया।
थैंक यू जावेद जी, इट वाज वंडर। आपने बहुत बहुत शुक्रिया आपका, आपने बहुत ही अच्छा प्रेजेंटेशन किया, और हम लोगों को बहुत नया आइडिया मिला कि कैसे हम दिवाली पे नए गिफ्ट तैयार करें। धन्यवाद, थैंक यू सो मच, शुक्रिया।
ओके, थैंक यू।
Now, Dr. Mahesh Verma, you are expert in compiling everything in a beautiful manner. So kindly let us know.
Yeah, firstly, wish to congratulate our leader, Dr. K.K. Agarwal, because every time it's a new learning, it's a new direction. He always, always excites us with his ideas, the research he does, and he brings out, a lot of good things for a social cause. And similarly, today being the 33rd meeting, and as a president of CIMAO, we feel proud that these activities are happening only in countries like India, where it is not happening at other platforms like America and other World Medical Federation level. And today, Dr. Kalra, he opened and he emphasized that most our cases are mild and moderate, and only in 10 to 15% cases we need hospitalization, and they only likely to become serious. So we need to have risk assessment, and we need to assess clinical and non-clinical parameters which can be made which are likely to make cases more serious. So we need to be preventive, and we have to have this approach. And Dr. Upasana Arora was chairing today's session. Dr. KK Agarwal opened, can I predict a patient going to cytokine storm? I think this is $1 million question. And if we are able to solve it, many, many lives would be saved. He came up with first hypothesis that we have been debating about prevention of virus and preventing disease so that cytokine crisis does not happen at all. I think that is what we've been doing all along. But there are other hypotheses where, can I give a drug on a day 0, or can I do something on day 1 so that cytokine crisis does not happen? And normal illness, COVID-19, we know that it takes about 4 days and 3 days recovery. So all about 7 days is over. But if you look at the weekly statistics world over, there have been different scenarios. There have been waves, different waves, 3 waves. And wherever there is a wave, it is also accompanied by mortality. In India, we still say that it's only 1 wave with fluctuations, and it's also matching the mortality pattern. Within India also, we are behaving differently. Delhi has seen 3 waves, and 3rd wave mortality is decreasing. We have seen it. In Maharashtra, only 1 wave, it is declining. Kerala, 2nd wave, and it is the pattern of mortality is very similar. Odisha, only 1 wave. Bihar, 1st wave. Rajasthan, 1st wave, but it is rising, and now declining. And Karnataka, very similar pattern. But if you look at the other countries, say in US, they had 3 waves, and mortality is reversed now. And I think if you look at, he emphasized that there are 2 patterns where we have more cases, more mortality, and there are less cases, more mortality. And the pattern in US is reverse pattern, less cases, more mortality, more cases, less mortality. Canada is very similar to US. Argentina, similar pattern. Peru, less cases, more mortality. Again, Latin American country, very similar. Iran is more like India. It has 3 waves. All the mortality is very similar. UK, Italy, Spain, very similar to UK, reverse pattern. That means less cases, more mortality. Mexico is like India. Hong Kong, 1 wave. Taiwan, 1 wave. France is like US and Canada, very similar to what is happening in North America and Latin America. Indonesia, Brazil, Saudi, Pakistan, Nepal, China, no mortality. And Indonesia, Brazil, Saudi, Pakistan, Nepal, there are more cases, more mortality. Something very similar to India. In Lanka, surprisingly, very less cases, no cases. Thailand, 2nd wave is happening, which is also matching with the mortality. Malaysia, very similar. So the end of the, the carry home message is, can cytokine crisis be prevented? That is what we are talking about. And he said, he has come out, that was one question. And the second question he raised, that he learned from an article published in Journal of Dental Research, that if a healthcare worker takes 3 times mouthwash with povidone iodine, it can prevent the COVID infection, especially for healthcare workers. And also, of course, it can be done for patients also. So in patients with COVID-19, we see a relentless self-amplifying cycle of inflammation and clotting in body. I think this is the basis of what is happening as a cytokine crisis. So this will precipitate cytokine storm. So if we can prevent clotting, we can win the game. On day 1, if we give aspirin, it will prevent platelet clot. And if you are high risk, take aspirin. And he advised many of us who are high risk here. And if you are not taking aspirin, start oral anticoagulants. And if the CRP level is high, how to know that cytokine crisis is being prevented? How do we know whether it was to come and we prevented it? All inpatient, those who are admitted in the hospital should receive thromboprophylaxis unless contraindicated. So all patients, and especially in India, we only have a home care in some of the countries where home care policy is not there. So 75% of people have anti-phospholipid antibody. He said this is again, a new learning that 75% of people already have anti-phospholipid antibodies. That is, they are in a hypercoagulable state, and it can be prevented by medication. So we know that 75% of our population is prone to coagulation. So we got to be very careful. And if CRP test is taken into consideration, once virus enters the body, CRP shall rise in 4 hours and doubling every 8 hours. And peaking happens in 56 hours, that is on day 2, after the day 2 is over. So it should come back to normal, normally in 90 hours. That is about in 4 days' time. If nothing to be done to patient, if it comes to normal in day 4. So we don't need to any intervention. But if on day 4, if value is double, then, and if CRP is more than 10 by day 10, it is leading to a cytokine reaction. So I think it's a great mind opening for us. So day 3, when CRP starts declining, and if it is more than 10 and fever more than 100, it is a cytokine reaction also. So that's another thing, that on day 2, day 3, if the fever starts rising again and CRP level is going up, and also there's a new onset of cough, that means cytokine storm has started. So to prevent, start day 0 aspirin, day 1 oral anticoagulants. And what is very crucial is CRP daily ratio and CRP doubling time. I think these 2 factors are very important. He said normal CRP is doubling in day 4. So to sum up, what he said is that if mortality is to be reduced, on day 1 start aspirin and atorvastatin. And if still gets COVID and CRP is more than 10 or at any given time of the illness, it means cytokine reaction has started. So severity of pneumonia goes hand in hand with level of CRP. So if the level of CRP is more than 10 during any duration, that means cytokine reaction has started, and we got to we got to do all the effort so that it does not go further. So bring CRP back to normal by aspirin and early and oral anticoagulants. Bring down CRP from level 10 during mortality so that it can be reduced. Dr. Upasana felt it was a good session. CRP being done by everybody and can be instrumental in bringing down mortality. Dr. Jayakrishnan, we have been endeavoring to decrease mortality all these months. So a single factor as prognostic for mortality is very useful. Dr. A.K. Agarwal, he said it's a good learning. And he also said that epidemiological data from all over the world, and especially SAARC countries, can be collected, and it can be the basis of assessing and comparing, are we doing well? And he also said about povidone gargle or hydrogen peroxide, will it be equally effective? In diagnostic field, we have so many parameters, he said. So if it can be communicated that CRP is the single most paramount, it shall be very good. Good from the cost point of view, and also from it will bring down the load on our labs. Aspirin, he had a question whether aspirin 75 milligram or 150 milligram. Dr. K.K. Agarwal said hydrogen peroxide can be a good substitute for povidone iodine. And also he said 150 milligram of aspirin is much better because it will have a much more potent action. Differential racial pattern like America, Middle East, European patterns, and seemingly difficult. So I think he also said that he is also studying the pattern in different races and how they are behaving in terms of mortality. Dr. Ashok Gupta, excellent information for high risk. Any data for secondary care establishment versus tertiary care for mortality, especially for infrastructure point of view. He said, is there any data available where we can say that it was how the mortality happened in secondary level and tertiary level from infrastructure point of view? Dr. K.K. Agarwal, infrastructure cannot be the only criteria. Learning from neighboring countries, vis-a-vis countries which have a very good infrastructure like America, Europe, they have a trial system, and it is not necessarily different. Dr. Upasana, how cases in Lanka are less? Well, a big question. Dr. K.K. Agarwal said Lanka has similar population like Kerala, so surge is expected there as well. Dr. Jayalal, good being focusing on a single factor good for the mass cases, especially because every practitioner is likely to get cases. And based on this, detailed protocol can also be worked out. Primary secondary care centers can adopt that protocols. And he said, Kerala and Sri Lanka are not same. He said, there is something more than that, and they are slightly different. Thailand, Dr. K.K. Agarwal, he thanked Dr. K.K. Agarwal on behalf of Indian Medical Association for this path-breaking information. And then we had a session from Jawad, Mr. Jawad, where he said water plants are hydroponics. They need 5 things. They need पौधा जड़ के साथ या बिना जड़ के साथ पॉट लें, चाहे वो बॉटल हो या फैंसी हो. मीडिया है, उसमें मीडिया में पानी हो सकता है, पत्थर हो सकते हैं, बालू हो सकता है, सैंड या कोकोपिट हो सकती है. बट एक चीज बहुत जरूरी है कि प्लांट में न्यूट्रिएंट डालें. ये प्लांट एक्सट्रैक्ट है जो प्लांट के एक्सट्रैक्ट से वेस्ट से बनाया जाता है, और 100 ड्रॉप्स आपने डाल ली हैं 1 लीटर पानी में. पौधे को पॉट में डालें और ध्यान रखें कि 1.5 से 2 इंच जो है उसकी जड़ जो है पानी में डिप होनी चाहिए. ये रूट्स पूरी ढक जाएं. दोनों किस्म के पौधे हो सकते हैं, जड़ वाले भी हो सकते हैं, जड़ रहित भी हो सकते हैं. इन्हें धूप, हवा या कहीं भी रख सकते हैं, और नए जो हाइड्रोपोनिक रूट्स हैं वो निकल आएंगी. 4 इसकी रेलेवेंस हैं इन पौधों के. एक तो एनवायरमेंटल है, हम पढ़ाई के लिए, रिसर्च के लिए, सोशल, कमर्शियल, एस्थेटिक. एंड बालू मीडियम में पानी डालें बीच बीच में, और फैंसी पॉट में अगर एक्वेरियम फिश भी डाल सकते हैं तो ये एक एक्टिविटी जो है बहुत ही कमर्शियल एक्टिविटी हो सकती है. और देयर आर मल्टीपल पाइप में मल्टीपल जगह लगा के छेद करके पौधे लगा सकते हैं, और इससे इनकम जनरेट भी कर सकते हैं. और ऐसे पौधों को हम एक्वापोनिक्स, हाइड्रोपोनिक्स नहीं, इनको एक्वापोनिक्स कहते हैं, जिसमें हम मछली और पौधे जो हैं उनको एक्वेरियम और हाइड्रो प्लांट जो है उनको इकट्ठा करें. उस जो स्टडी को एक्वापोनिक्स कहते हैं. उपासना जी ने जवैद साहब का बहुत बहुत धन्यवाद किया. थैंक यू सो मच.
I just want to take half a minute because assignment दिया था डॉक्टर अरुण अग्रवाल ने, तो मैंने वो असाइनमेंट साथ के साथ में पूरा कर लिया है. I'll take 2 minutes. डॉक्टर अरुण अग्रवाल, ये वर्ल्ड का है, ये इंडिया का है, ये इंडिया की वेरियस स्टेट्स का है. इंडिया की वेरियस स्टेट्स का पैटर्न है, ऊपर केसेस नीचे मोर्टेलिटी. ये यूएसए और कनाडा और मेक्सिको का है, सेम पैटर्न है. ये ब्राजील, पेरू, ये नॉर्थ साउथ अमेरिकन कंट्रीज का है, सेम पैटर्न है. ये ईरान और इराक का है, सेम पैटर्न है. ये यूके, इटली, जर्मनी, स्पेन, फ्रांस, रशिया, सबके पैटर्न सेम टाइप के. अलग अलग पैटर्न्स और सब अलग अलग कॉन्टिनेंट के मैं ले रहा हूँ. अफगानिस्तान का मैं और लेकर आऊँगा. एंड देन यू कैन सी दिस पैटर्न्स ऑफ हांगकांग, ताइवान, साउथ कोरिया, सिंगापुर, चाइना टुगेदर. यू कैन से दे आर ऑल फॉलोइंग द सेम पैटर्न. ये सऊदी अरेबिया का है, बाकियों का मैं निकाल रहा हूँ अभी. ये पाकिस्तान, नेपाल, बांग्लादेश, लंका का पैटर्न है. ये ऑस्ट्रेलिया, न्यूजीलैंड का पैटर्न यहाँ पर आएगा. ये बाकियों का मैं निकाल रहा हूँ. सो यू कैन सी एक्चुअल में कॉन्टिनेंट्स आर बिहेविंग डिफरेंटली. आई विल इससे ज़्यादा मैं बना नहीं पाया, बट आई एम फाइंडिंग कि सारे कॉन्टिनेंट्स को मैं इकट्ठा दिखाने की कोशिश कर रहा हूँ टू सी वेदर कॉन्टिनेंट्स आर बिहेविंग डिफरेंटली. द आंसर इज यस. ओवर टू डॉक्टर कालरा.
Thank you, sir. It was a really very fruitful session. And key message from today's discussion was the use of a single test to predict the seriousness in a patient of COVID-19, that is CRP. And starting early, rather than zero, in all high-risk patients, all high-risk individuals aged more than 65 years or other having comorbidities, they should start aspirin 150 milligram per day. And any patient who has CRP, even on day 3, more than 3, then definitely think starting the aspirin plus oral anticoagulant early.
More than 10.
More than 10, sorry. Yeah, more than 10. Think start early. That can prevent the complications which are known, thrombosis, thromboinflammation, then other autoimmune inflammation. Is a vicious cycle of both. So that is a very useful information. Single test very, very cost effective, and all this can be done in all kind of laboratories everywhere. So it was a very, very useful information today. I thanks all the chair as well as all the participants for attending and having interactions today. And again, see you again for the next Saturday, same time we'll meet again with a new topic.
Thank you, everybody.
Thank you, Dr. K.K. Kalra. Thank you, Dr. K.K. Agarwal, Mahesh.
Thank you.
As usual, you bring the best possible summary. Upasna ji.
Thank you. Thank you.
Our wonderful chairperson.
Thank you, sir.
Thank you so much.